Just a minute. Okay, let us start now. So radio frequency is a procedure, is a kind of neurolytic procedures used in pain management. So there are lots of myths about the radio frequency. Some fields radio frequency term came because something is done distally, like the radio wave transmission. Means without any physical contact. What happens in the radio wave transmissions? So there is a transmitter and there is a receiver, transistor, radio, and the wave is coming from the transmitter to the receiver, and we are hearing the music. But same thing unfortunately has been the compared with the radio frequency procedures, and unfortunately it is not the same. The term radio frequency came because of the same frequency what is used in the radio wave transmissions and what we are using in the radio frequency ablations are the similar band, and that is the name came from the radio frequency. Means frequency band is same as what is used in the radio wave transmission. That is how the term came. Otherwise, there is no other relations. And don't never think that the radio frequency procedure is possible without a physical contact. Physical contact is must to have the procedure. So what in my lecture, what I'm going to demonstrate is the principles. We should know what exactly happens in radio frequency ablations, or not just ablation, radio frequency procedures, I should say, because there are also some non-ablatory radio frequency procedures are there. So let us start. So neurolysis. What is neurolysis? Neurolysis is a process of the ablation of the pain-carrying nerves. It is also done sometimes, in the in management of the spasticity, particularly done by the physical therapy physiatrist. But for the pain management people, it is the ablation of the pain-carrying A delta and C fibers. It is done in many situations, mostly in the intractable cancer and other painful conditions. Basically, it's a kind of palliative procedure. We are trying to stop the pain signals, not allowing them to reach to the brain. So it can be done by the several ways. The most the primitive and the most the earliest ways was the surgical ablations. Means we are cutting the nerve and we are stopping the pain signals reaching to the brain. And nowadays there is a modernizations. There is a endoscopic way what we can do. So the other ways to do it by the chemicals. Chemical is still now popular, particularly the alcohol, phenol, glycerol, and the hypertonic saline has been used. Just a minute. Sorry for the interruption. So the advantage of the neurolysis is we are giving the we are ablating the nerves, we are giving the long-term pain management and long-term pain relief, and we might be able to withdraw the drugs, or we might be able to reduce the doses of the drugs, and side effects of the medicines. If we are stopping the medications are less, and if we are calculating in the long run, it is cost effective than the medical management. So it's a kind of palliative therapy, but in the long run, it is more comfortable for the patients, and of course long run it is cost effective. The disadvantages of the neurolysis are there are some failures. Particularly, you need to have the proper skill to do it. At the initial period when you are doing it, it is a little bit costlier, and there is a possibility of the inadvertent damage of the surrounding nerves. So if you are targeting certain nerves, say for example, you are planning to do the the stellate ganglion. So all around there are a lot of important structures. You are having the nerves of the brachial plexus, we are having the the recurrent laryngeal nerves, we are having the phrenic nerves. So inadvertently we might be damaging the other nerves. So it is a riskier procedure compared to the medical management pharmacotherapy, and there is a possibility of the deafferentiation pain. So what is deafferentiation pain? If it is a mixed nerve and if you're ablating it, so that area might be numb, but because of the sensitizations and because of the other changes, so it is possible that the pain is produced from that part. So a numb part, the pain is still there. This is called the deafferentiation pain. So this is also a very important possibility after the neurolysis. So these are the disadvantages. And exactly what is the mechanism of the deafferentiation pain? It is beyond the scope of this lecture. But just remember the two important mechanisms. One is crosstalk, means after you are ablating the nerve, so the nerve might be regenerating and nerve might be talking with each other kind of fiber. So A beta fibers carrying the touch sensations might be talking with the A delta fibers carrying with the pain. So the signals from A beta fibers might be transferred because of the crosstalk to the A delta fibers. So this is crosstalk. And ectopic signal is basically the sodium channels is manufactured in the cell body, transferred distally along the the axons and dendrites. But if there is a the ablations, they cannot go beyond. So they are accumulated at the cut end, and that can cause the accumulation, and which is responsible for the ectopic signal generation. So this is the responsible for the deafferentiation pain. So whenever we are doing a neurolysis, always remember that one of the very important disadvantage of the neurolysis is the deafferentiation pain. So in some around the incidence is around 1% to 5%, and depending on what kind of procedures you are doing, what degree of the nerve damage you are doing. If you are doing more than the second degree nerve damage, then this possibility of the deafferentiation pain is there. If it is up to second degree nerve block, which is called axonotmosis, or the regeneration is perfect, the deafferentiation pain is not possible. But if you are doing it more than that, second degree, third degree, fourth degree, third degree, fourth degree, and fifth degree, deafferentiation pain is possible. So now the basics about the electricity, and unless we know these things, we won't be able to understand what is radio frequency. So we are having the two types of current. Two types of current means either it is a direct current or it is an alternating current. So what is the direct current? If I am having the two, the poles, then the current is flowing always from the one pole to the another. And what is alternating current? Here the direction of the current is changing, and that's why it is alternating current. So direct current, like dry cell, mostly it is the direct current. Whereas in the household electricity, what we are using here is mostly the alternating current. So almost all domestic electricities are basically the alternating current. The instruments also different, like the fan moving, ceiling fan, the direct ceiling fan and the alternating ceiling fan are different. So now second very important, some of the units we must be knowing to understand the radio frequency very nicely. So number one is your Hertz. Very commonly use it. What is it? Alternating current, whenever you are talking, we should be knowing that alternating current frequency is denoted by the Hertz. What is Hertz? In cycle per second. So that means how many times it is changing its direction in the alternating current is the Hertz, or the frequency of the alternating current. So like in the household electricity, what is the it is uniform. Might be varying in some countries, but mostly it is the 50 Hertz alternating current in the domestic use. What is the meaning of that? That means the electric current is changing its direction 50 times per second. Imagine, very fast. 50 times it is changing its direction per second. So household domestic electrical current is 50 Hertz in frequency. Next important thing is your voltage. So what is the voltage? Voltage means potential difference between the two ends. So one, and this is another end, another pole. So what is the potential difference between these two? And this is basically the driving force. So because of this voltage changes, then only electricity will flow. The voltage is same, potential difference is not there, the electric current will not flow. Then next is your ampere, or denoted by A. What is that? It is the rate of flow of the electric current is your ampere. And another is important is your wattage. Very frequently I talk what is the wattage you are using in our radio frequency. So wattage is the voltage into ampere, or it is the power of the electricity. So how it is done? In a very simple example is given here. So ample, suppose there is a the pipe through which the water is flowing. So how much water is flowing, rate of the flow, that is denoted by the ampere. That is the rate of flow of the electricity. That is your ampere. Then is your voltage. So water will be flowing only when the pressure on the one side is higher than the other side. Then only the water will be flowing from higher pressure to the lower pressure. So this pressure difference or the potential difference in case of the electricity is denoted by voltage or V. And what is wattage? This force of the electricity, the water, if you are comparing with the pipe, which is the transferring the water, the force of the water, like this force of the water can be used in some of the purposes. So like turbine is rotating. So this force of the water. So this is the power of the water. So that is denoted by the watt. So these parameters we'll be keeping in mind, because this hertz, the volt, the ampere, the wattage, very frequently using when you be operating the machines, radio frequency machine. These terms will be coming very frequently. So remember these things. Hertz is the frequency, number of times it is changing its direction. Voltage is the potential difference between the two ends. The ampere is the rate of the flow of the current, and wattage is the multiplication of the rate of the flow with the voltage. That means it is the power of the electricity is denoted by the wattage. So now, what is exactly what we are doing in the radio frequency procedures in our pain management thing? So here, we are using the converting the 50 hertz alternating current. What we have just now we told that in the household electricity, domestic electricity, we are using 50 hertz current. What is the meaning of that? That is an alternating current which is changing its direction 50 times per second. So now a radio frequency machine, the input current will be what? 50 hertz, but its output current, that means the machine is converting the the electricity 50 hertz current into a 300,000 hertz alternating current. So machine is converting it. Machine is converting the 50 hertz current into 300,000 hertz alternating current. So this is what is a radio frequency machine. So radio frequency machine is nothing but input current and output current. So is different. So the procedure is called radio frequency. Why I told you that this frequency band, that means 300,000 band, is similar to that of the radio wave transmission band. And that is the reason why this is called radio frequency machine. So now the what happens? So we are applying this current. The circuit will be completed in the body. So we're putting one, the ground tag and another electrode. So electrode is basically passed to the needle, and that when it will be circulated through. Normally the electrode is a 27 gauge thermocouple probe, and it is passed through a needle or cannula. It is most commonly called the radio frequency cannula. And its size might be varying somewhere between the 14 gauge to 22 gauge, the cannula, and we are putting it there. So what is happening there? So when the electricity circuit will be completed, so there is light body, means there are lots of charged ions, non-charged ions, positively charged, negatively charged. So when the electricity will be there around the electrode, that means around the needle where the electric current is very strong, this charged particle will start oscillating. The charge will be moving, oscillating at which rate, at which frequency? At the same frequency, same rate of the electricity. So the change of the the electric current direction, this direction of the charged particles will also be there, and that means 300,000 times per second the charged particle will start moving. So positively charged ions, negatively charged ions will be moving in the opposite direction, and the non-charged, the neutral, is not moving. So there will be friction between these, the different charged ions and the non-charged ion, and this friction is going to generate the heat. So this is the principle how this heat is generated and how there is a thermal ablation with the radio frequency. So remember that this heat is very precisely located around the electrode. Electrode means the needle with thermocouple together. Radio frequency needle or radio frequency cannula with thermocouple together, that is generating this heat around it. So this probe itself is not heated. So where is heat? Heat is generated in the tissue where there is a movement, there is a friction, And what is the function of the probe? Probe is sensing the temperature, sending this feedback to the machine that, okay, we have attained this temperature. And then what the machine will do? Otherwise, temperature will go up, go up, go up. So the machine, as soon as it senses that, okay, my temperature has been attained, immediately it starts reducing the wattage. As you told, the power of the electricity is denoted by watt. This watt is basically the machine is controlling this watt to generate the heat. Once the heat is reaching suppose I have set the temperature at 80 degree. That means we want the lesion to be done at the 80 degree temperature. But as soon as we are reaching it, the watt starts coming down so that the temperature is regulated at 80 degree. So remember that whenever you are doing the conventional radiofrequency or thermal ablation, the temperature of the around the probe, surrounded the probe, is basically controlled by the machine by getting the feedback from its thermocouple by the probe, and it starts reducing the wattage. As soon as it will be reducing the wattage, that means the power of the electricity, the temperature will be not maintaining that. Then again it starts falling. Then again the wattage will be increased by the machine. So this increase and the decrease of the wattage is determined by the tip temperature as assessed by the thermocouple in the probe. So now this is one of the schematic diagram. So this is a machine, and the input, the domestic current, 50 hertz current, and the machine is converting this current into 300,000 hertz alternating current. And there is a ground pad where the electricity is dispersed in a wider area, and that is not going to, so that if it is a dispersed in a wider area, the intensity of the current is reduced to such a level that the movement is very weak and it is not going to produce any thermal lesion. So remember, if the length of this needle or this area is more than 15 millimeter, 1.5 centimeter, then there will be no lesion. So the probe, the bare area or the uncovered, so that this needle, radiofrequency needle, is basically like a nerve stimulator needle. So it is insulated except the tip. So the tip is exposed, and that is the active electrode. And inside it, we are putting the thermocouple, the thermocouple, and that is becoming a electrode. So this electrode, the exposed tip, should not be more than 1.5 centimeter. If it is more than 1.5 centimeter, what will happen? The electricity will be dispersed, and there will be no, the good lesion there. So this is how the electricity is, the transmitting to the body's the electrolytes, and the circuit is completed. And this is the circuit for the conventional thermal radiofrequency. So now the principle how we discussed, that the probe itself is not heated, and the lesion size in a conventional radiofrequency is around 2 to 4 millimeter. Means beyond that, the electricity is dispersed so much, the electricity is very weak to produce any thermal lesion. So the size of the lesion is 2 to 4 millimeter, not more than that. So it is that has the advantage and disadvantage. What is the advantage? That it is not going to damage the surrounding tissues. But what is the disadvantage? If your needle is little bit away, that means if it is more than 4 millimeter away, your nerve and the needle or the RF needle, there will be no lesion. That means there will be failure will be certain. So it has both the advantage and the disadvantage. And normally the tip temperature is selected by the machine. We can select how much, the target temperature. It can be, on you. The thermal, the lesion or the heat ablation normally is done between the 65 degree to 90 degree. Below that, the ablation is not good. So now, how the tip temperature is controlled, as I told you, that as soon as we are attaining our desired temperature, the wattage starts reducing. Remember what is wattage? What is the power? That is the multiplication of voltage and the ampere. So machine is sensing it, and machine is changing the wattage. So that is how the tip temperature is maintained. But at the expense of what? At the expense of size of the lesion. That means if the wattage, so there is a linear relationship with the wattage and the size of the lesion. That means if the wattage or the power of the electricity is more, then the size of the lesion will be more.
So what we are doing here, we don't want the charring, of the tissues. We don't want the temperature to go beyond 80 degree or 90 degree. Then there will be charring and there will be a lot of other complications. So to maintain that tip temperature, what machine is doing? Machine is reducing its power of the electricity. That means reducing the wattage. At the expense of what? At the expense of size. That means the size is not going to be more than 4 millimeter. 2 to 4 millimeter is the range, and that is because the machine is reducing its wattage to control that. So now in the conventional radio frequency, this electricity is continuous. That means 300,000 hertz electricity alternating current is delivered continuously between the two electrode, or one electrode and another is the ground pad. But there is another kind of radio frequency which is called pulse radio frequency, where it is given in pulse. Means, so I have tried to explain this in the schematic diagram. So that means this is the active current, where the electrical frequency is your 300,000 hertz. Then there is a silence, no current. Then again 300,000 hertz current. Then again silence, no current. Then again, so this goes on in the pulse radio frequency. So what is the advantage for that? Advantage is, by giving the silence, we are not allowing the temperature to rise more than 42 degrees Celsius. That means the pulse radio frequency, we are giving the high frequency alternating current in pulse, in packets, with a silence in between. And by that way, we are not allowing the temperature to rise more than 42 degree. Why 42 degree? Because it has been seen that in our body, there are the tissues are the different kinds of tissues having the the different temperature, the heat labile temperature. But 45 degree, below 45 degree, no tissues are damaged with the heat. So we are keeping still at 42 so that there will be no damage of any structures by heat. So pulse radio frequency is one way. It's very safe that we are not going to damage any tissues with heat. So the pulse radio frequency is safer, but pulse radio frequency have the failures as well. So now a little bit more details about the pulse radio frequency. What is done here? So when you're talking about, we are delivering the packets of the alternating current in between with the silence. Two important things to remember. One is, what is the duration of this active current? So how long we are giving this active current, and how frequently we are giving this active current, or what is the gap between these two active current. So that is what is determining that what is the pulse radio frequency parameters. So remember, the most machines have this parameter, 2 hertz, 20 millisecond pulse radio frequency. What is the meaning of that? Means 20 millisecond is the width of the pulse. That means we are giving the active high frequency alternating current of through 300,000 hertz for 20 millisecond. And then we are giving a silence. And then we are giving again the current. So how frequently we are giving? 2 hertz. 2 hertz means 2 times per second we are delivering. So 2 times per second we are delivering, and each time we are giving for 20 millisecond. This is your 2 hertz 20 millisecond pulse radio frequency. And what is the silence between these two? Is here is your 480 millisecond. How it is coming? Because we are giving it 2 times per second. So 1 second is equal to 1000 millisecond. So each cycle is 500. Out of this 500, 20 millisecond is the active current and 480 millisecond is the silence. So this is how we are delivering the pulse radio frequency. But it is not that we have to give it as a 2 hertz 20 millisecond. We can change the parameters. So there are sophisticated machines where you can change these parameters. Say for example, I want to deliver it as a 5 hertz. I want to deliver the duration of the current as 10 millisecond or 25 millisecond. So it is my choice. I can change it. But most of the machines, there is no option of changing this frequency and the milliseconds of the pulse radio frequency. So pulse radio frequency, what we are doing? So pulse radio frequency, we are not doing a thermal ablation. Now the question is, how pulse radio frequency effective if we are not raising the temperature? So the answer is, when we are delivering the high frequency alternating current, there is a development of the strong electromagnetic field around the electrode. And this strong electromagnetic field can be having another physiological effect. So what is this physiological effect? It is definitely not the ablation effect. So thermal radio frequency is producing ablation, nerve ablation. So radiofrequency ablation term should be preserved for the the conventional radiofrequency, but not for the pulse radiofrequency. In the pulse radiofrequency, we are stimulating the tissues. What we are stimulating? Again, there are a lot of the debates about what we are basically stimulating, but it has been seen that some of the genes in our body are getting expressed with the pulse radiofrequency, so that there is the development of some of the interleukins, which is having the anti-inflammatory property. So there is a wide range of interleukins. Some interleukins are pro-inflammatory, produces pain. Some interleukins are anti-inflammatory, reducing the pain. It has been seen that with this pulse radiofrequency, that means the strong electromagnetic field that causes the stimulates the genes and starts producing some of the peptides and the interleukins, which is having the anti-inflammatory property. But still, it is not convincingly proved. There are certain other hypotheses how pulse radiofrequency is effective. But you have to remember, the pulse radiofrequency also have a lot of failure. So if we are comparing these two, this is this image has been taken from the Charles Gauzy. So this is your exposed tip, and this is the lesion here. The lesion is maximum at the level of the shaft, and see at the pulse radiofrequency. So here the tip is where the strong electromagnetic field is produced, not at the shaft. So this is the difference, that when we are doing a conventional radiofrequency, we'll be trying to keep this part in contact so that there will be wider area of the lesion. Whereas, and we'll be trying to place the needle parallel. Like if your needle is passing like that, you'll be trying to put the probe, like parallel, so that not exactly parallel, but it should be close to parallel, so that the area of the lesion will be and the larger and the stronger. Whereas when we do the pulse radiofrequency, what we do, we try to put, if this is a needle, we are trying to put it perpendicular, because the strong electromagnetic field around the tip, so it will be having the better lesion. So if we are comparing the other things, so it is the 65 to 90 degree for the conventional radiofrequency, whereas 42 degree is for the pulse radiofrequency. So the advantage of the pulse radiofrequency is it does not cause any nerve damage. These are most important. So it is very safe. And if it is not ablating anything, then there is no chance of any deafferences and pain. That means deafferences and pain related with the crosstalk and the ectopic signals are related with the damage or the degree of the damage of the nerves. So in the pulse radiofrequency, you are not damaging anything. So it's very safe. It is not going to produce any deafferences and pain. But disadvantages are there is a high failure rate, and the duration of pain relief is shorter. So pain-free period in the conventional radiofrequency can even go up to 10 years. In the trigeminal neuralgia radiofrequency, you have seen the patients are enjoying the pain relief for almost 10 years in certain situations. But whereas in pulse radiofrequency, the duration of pain relief is shorter. Now, another very important kind of radiofrequency now is becoming very popular is called cooled radiofrequency. So what is cooled radiofrequency? Don't have this mistake that the cooled radiofrequency and the cryoablation are different. Cryoablation is we are applying the temperature minus negative temperature, and we are freezing the tissues at minus 18 degree centigrade. Whereas in the cooled radiofrequency, you are still doing the thermal ablation at around 60 degree to 90 degree or 60 degree to 80 degree. But here it is called cooled radiofrequency. Why? Because if you are remembering the principle, how the tip temperature is maintained by, as soon as I told you, thermocouple is sensing the temperature, giving the feedback to the machine. As soon as the machine understands that my tip temperature has been reached to the desired level, then the wattage starts coming down. So by changing the wattage, the machine is controlling the tip temperature at the expense of what? At the expense of the size of the lesion. Size of the lesion is smaller. Why? Because we are unable to deliver the current at a higher wattage. And that disadvantage has been taken off by the cooled RF. So what we are doing at the cooled RF? So here there is a channel. This is the blue line here. This is again a schematic diagram. Where the water is passing through this. So water when passing through this needle. So this is a needle through which there might be the stellate, and this cannula. We can introduce the needle, and through that cannula there is a circulating channel through which the water passes at the room temperature. So what happens? it takes away the temperature. So here the tip temperature is controlled by what? By circulating water. The water takes away the temperature and water controls the tip temperature. So what is the advantage? You can deliver the current at a higher wattage. And if you are delivering the current at a higher wattage, what will happen? The size of the lesion will be bigger. So cooled radio frequency, the very important advantage is you can have a larger size lesion. And you understand how the larger size lesion is produced by controlling the tip temperature by circulating water. And next is your bipolar radio frequency. So bipolar radio frequency, what is happening? So this schematic diagram compared to the other. So this part is not there. So you are having the electric current will be the circulating between these two electrodes. So it will be coming here and coming back. So this part is not needed. So here we will be putting two probes side by side, and there will be size of the lesion which will be wider than if you are doing a monopolar. If you are having only one probe, then the size of the lesion will be smaller. But if you are putting two and the lesion is there in both the probe, you will be having a larger size lesion. So cooled radio frequency is an option how we can have a larger size lesion. Same way, the bipolar radio frequency is also going to produce a large size lesion. Now, another very important is your multi-channel radio frequency. So the multi-channel radio frequency means you can simultaneously do 2, 3, 4, 5 lesions together. So nowadays sophisticated machines are there. Here it is a multi-channel means two probe, two channel. There are certain the machines which can produce the 4-channel lesion. So what is the difference between the bipolar versus multi-channel? So remember, this is a multi-channel. Here we are having the two probe, but here this is also present. So how this, there are two probe which is producing lesion simultaneously. So how the electricity is passed? So through this channel, electricity is passed like this. Another is passed like this. So the two circuits here, this is important. Whereas what was happening in bipolar? So bipolar, this part is not there. So the current is passing between these two. This is bipolar between the two electrode. But here the electric current is not passing between these two. One channel is like this, another channel is like this. If you have 3, another channel is like this, 4, another channel like this. So all is having the individual circuits. So machine divides like a 2 machines or 3 machines or 4 machines. So the ground plate is common, but individual circuit between each of the active electrode. So that is your multi-channel, having the multiple listens together. This is the difference between the bipolar and the multi-channel radio frequency. So with this, we are having also a lot of different types of the cannula. So it can be the curved, it can be the straight. How much is the exposed tip? I told you, the exposed tip should not be more than 1.5 centimeter, 15 millimeter. Why? Because if it is more than 1.5 centimeter, the electrical current will be dispersed. It will be weak and there will be no lesion produced. And the size of the lesion can be from 5 millimeter to 15 millimeter. The gauge of the can be from 14 gauge to the 22 gauge. So depending on how much is your size, the length and the size width you can do. Depending on that, there are different varieties of. And nowadays there are certain newer cannulas. So 3 different newer cannulas to have a larger size lesion. So this is a protruding cannula. So what is happening here? So after putting this needle, so there is a side hole through which another needle comes and it produces the larger size lesion. So this is a comparison between the monopolar, this is a cooled RF, and this is the protruding electrode. And still you can see the cooled radio frequency having the higher size of the lesion. This is a venom cannula. Venom cannula is having the, again, almost similar to that of the protruding cannula. So after passing it, you can separate these two. And this is a trident cannula, or basically there will be 3 different, the needle tip is dividing into 3, and again is having the larger size of the lesion. So these are the different ways by which you can try to make a size of the lesion. So here, the different cannula, again, you can see if you are doing the pulse radio frequency, we are having on the tip, but the size is smaller. So this is for the conventional, this is for the cooled. Remember the shape of the lesion between the conventional and the cooled is having the larger size lesion, as well as it is a spherical lesion, not a cylindrical lesion like the conventional one. And this is your protruding, and this is your bipolar. Bipolar means 2 conventional electrodes, and you are having larger size lesion like that of the the similar size of the cooled radio frequency. But one disadvantage of the of the bipolar is you are not having any lesions beyond the tip. But here, cooled frequency beyond the tip will be having the significant size of the lesion. That means even if your needle tip is little bit away from your nerve, still you can catch the nerve. But here you should be having the nerve in between the two electrodes or side of the electrodes, but not the beyond the tip. If it is beyond the tip, you might be missing the nerve, whether it is a bipolar or conventional. Bipolar and conventional is almost similar. So now this is another very important curve which shows the size of the lesion with the time. So initially, up to the 60-second, it is, the more you are increasing the time, more will be the size of the lesion. But once you are attaining the 60-second, then even if you are increasing the time, still there will be increase of the size, but that size is very, very, very insignificant. So normally the recommendation of the duration of the lesion is somewhere between the 60-second to 120-second for the conventional frequency. Why? Because the maximum size of the lesion is attained by 60-second. From 60 to 120-second, still there will be very marginal rise of the size of the lesion, but that is very nominal. Most of the time, most of us do the 90-second. So because after 90-second, the increase of the size of the lesion is almost insignificant. This is for the conventional, but for the cooled frequency, normally we go a little bit more beyond. So there, the chances of the size of the lesion is, this curve is not for the cooled RF. So there the recommendation is go up to 2.5 seconds, 2.5 seconds, because there the increasing the size increases the size of the lesion, increasing the time increases the size of the lesion more than this conventional lesion. So remember, it's not that if you are doing a lesion for 1 hour, you'll be having a very big lesion this size, never. So after reaching the certain level, then you will plateau. Then increasing the time is not going to increase your size of the lesion. So now this is very important. Very frequently, this is one of my very favorite, and not mine, just many examiners' favorite questions, is how we are going to have a larger size lesion. So what are the options? Number one is if you are increasing the gauge of the needle, like 22 gauge needle and your, the 14 gauge needle. So what is the 14 gauge needle itself is around 1 millimeter thicker. So you can do that, but at the expense of pain. If you are using the 14 gauge needle, it will be hurting more to the patient. But still some people prefer to go for the 14 gauge needle. Then is increasing the time, again not for the indefinite period, but from 60-second to 90-second, you can increase the size a little bit. If you're using the cooled frequency, then you can have a very big size lesion. If you're using the bipolar frequency, or if you're using the newer cannula, like protruding electrode, like venom electrode, like the trident electrode, then also you might be having a larger size. So these are monopolar electrode. When you're using this, trident or protruding electrode, you are using a monopolar radio frequency, but still you are having the larger size lesion because your needle tip is bifurcating and you are having the covering the wider area. So this is how we can increase the size of the lesion. Then is your, how to confirm that we are close to the nerve. So this is very important, that we should be close to around the 2 to 4 millimeter around the nerve. If you're a little bit away, you will not be able to do the lesion. So how to understand? The most important is here, the C-arm guidance is the most wide, particularly for the spine. C-arm is the most important option. Nowadays USG also, but remember the final nerve can't be seen by the ultrasonography as well. So what we need to do? We have to do the sensory stimulation. So what is sensory stimulation? That if we are delivering 50 Hz current, remember one very simple rule, that larger the diameter of the nerve fiber, the lesser is the frequency to stimulate. Just now I told you what? The direct current and alternating current. Alternating current is changing the direction of the current. So how we are indicating it? By the frequency. How many times it is changing its direction is the frequency. So if the frequency of the alternating current is less, like 1 Hz, 2 Hz, then the largest diameter motor fibers will be stimulated. If you're increasing the frequency of the alternating current, then we'll be able to stimulate the smaller diameter, not the larger diameter. Larger diameter fibers will be escaped. That means if we are stimulating at the 50 Hz or 75 Hz or 100 Hz current, then what will happen? Then we are going to stimulate the smallest diameter fibers, C fibers, A delta fibers, and we will not be stimulating the motor fibers. So by giving the frequency of 50 Hz current, we can stimulate the sensory fibers. and patient will be feeling some tingling sensations or sometimes pressing sensations. And this should be obtained not by a very high voltage. The voltage of the electricity should be somewhere at around 0.5 to 0.6 voltage. If we are able to stimulate, able to elicit the paresthesia, tingling sensations with that low voltage current of 0.5 to 0.6 volt, then you understand your needle is approximately 2 to 4 millimeter away from your nerve. That means we are close to the nerve. But second important part is we should not be close to the nearby other nerves. Particularly, we are afraid of the motor nerves. So what we need to do? We need to stimulate it the motor range. That means 1 to 2 hertz range, and see that the other nerves, which is not our target, are stimulated. Particularly, the motor fibers are not stimulated. So we are giving the current at 2 hertz. Most machines has the default setting of the 2 hertz, and with that, we try to understand that your inadvertent stimulation of the motor fibers is not there. So then we understand that we are properly placed. So this is also called the sensory motor dissociation. So what is sensory motor dissociation? That means when we are delivering the current at a certain voltage at 50 hertz and we see that there is a stimulation, then you are doubling the current. Say for example, you are stimulating at 0.5 voltage, and now you are giving the current at the 1 voltage, and still the inadvertent motor fibers are not stimulated. This is called sensory motor dissociation. That means our nerve is close to our target nerve, but our nerve is not close to other inadvertent nerves which might be around. So you will be giving the current, double the current at where we got the sensory stimulation, and you see that there is no inadvertent stimulation. Then you confirm that your needle placement is proper. These are the list of the procedures which are done by commonly by the radio frequency. Gaussian ganglion will be the one of the important which we'll be demonstrating today. And the pulse radio frequency, the failure is high, but still there are certain situations where the pulse radio frequency has still been tried. Most important evidences are there in favor of the cervical dorsal root ganglion, but thoracic lumbar can also be tried. Occipital nerve, suprascapular nerve, intercostal nerve, these also are the areas where the pulse radio frequency has been tried. But nowadays, the cryoablation is the preferable one, with which I'll be, later on I'll be talking about the cryoablation when we'll be talking about the details, a little bit about it. But remember, the pulse radio frequency will have a very high failure rate, and there are the 4 areas where some evidences are there. The strongest evidence are there in favor of the cervical dorsal root ganglion. The cool radio frequency, they are the least where the cool radio frequency is having the big evidences, particularly the sacroiliac joint and some of the other areas where the cool radio frequency, like the hip, like the knee, the shoulder. So the other areas where the cool radio frequency have the good evidences. Bipolar radio frequency, again the evidence according to the evidence base, the sacroiliac joint, lateral branch. We had a very early publication in 2014, the bipolar radio frequency in the sacroiliac joint. Then there are certain other areas where the cool radio frequency is used. All these areas can be a good choice for the bipolar radio frequency. But again, the evidence level in favor of the bipolar radio frequency is not as strong as the cool radio frequency. So thank you for joining. So I'll be taking a little bit of gap. Now Dr. Palak will be demonstrating talking about the trigeminal neuralgia. And before Dr. Palak is starting it, if you have any questions, quick 1 or 2 questions, I can try to answer it. Any questions regarding the principles of the radio frequency? We are not individually talking about each procedures. We have already demonstrated the many of the procedures under the CM, like medial branch of the facet joint, one of the very commonly done procedures in the conventional radio frequency, like transforaminal for doing the DRG. So these are some of the common areas which already has been demonstrated. Today, as we told, Dr. Devjit will be demonstrating the trigeminal Gaussian ganglion, and right now there will be one of the trigeminal neuralgia lectures which will be given by Dr. Pala.